this middle portion. If you look at this, we said, the peak incidence is in the 60, 70 years, but data in Nigeria suggests differently. And they also they went around to look at all the data from developing countries, and they found that truly renal cell carcinoma seems to occur a little bit earlier in developing countries, including Nigeria. And you look at it's mostly in the 5th decade of life in Nigeria. And then, of course, most of them do come late. Now, so in terms of etiology, therefore, we do not really know because most of the studies were silent on the risk factors in our patients in Nigeria. But a study from Ibadan by Bakmos and Tijani in Lagos, stated that most of their patients, or a significant number of their patients, smoked, and they found renal cell carcinoma in this sort of patient. Now, so in terms of etiology, the factors the risk factor could be sporadic or hereditary. Our patient, do they have hereditary, predisposition? We do not know, because most of these studies will not mention those things. But the most significant risk factor, whether in Tijani's study or Batmos one, is smoking. The smoking seemed to be the most acceptable risk factor for renal cell carcinoma. And chemicals, westernized diet, diet high in fat and high in protein, low in vegetable. This is Western diet. And of course, obesity or anatomical problems or pathological problems of the kidney, polycystic kidney, or acquired, renal cyst. All these ones, the relative risk is quite low. And sometimes it's doubtful if they really contribute to the causation of renal cell carcinoma. Most of these studies that try to draw this attention to these risk factors are case control studies, and they are observational. And they are, therefore, the linkage to causation has been really weak, right? So in terms of hereditary, this has been the most revealing of the search for the etiology of renal cancer. Now, von Hippel-Lindau disease, which is a cancer syndrome, in which renal cell carcinoma is just one of them. Now, patients that have mutation of VHL-G, manifest clear cell RCCs, and these patients, these patients or the patients that have sporadic form of RCC also who have clear cell RCC also seem to have this same gene mutation. There's 75% of patients or families who have von Hippel-Lindau disease, gene mutation and develop RCC, and up to 50% of sporadic cases of clear cell carcinoma also have this sort of problem. The mutation of VHL-G. So there are other, hereditary forms of renal cell carcinoma, and these include the hereditary papillary RCC, which present with the histologic, the papillary form of RCC, which we'll come to very shortly. And then, of course, the hereditary leiomyosarcoma, the leiomyoma RCC, which present with the type 2, just for to differentiate it from the hereditary papillary RCC. And this one is a type 2 papillary RCC. And then, of course, the Bitt-Hogg-Dubé syndrome. Now, this, all these cancer, syndromes or genetic defects have been clearly studied. And for patients that come with the sporadic forms, they seem to also manifest some of the mutations that you find in the genetic or hereditary RCC. Therefore, it looks to many that RCC, heterogeneous disease, is actually a genetic disease, and environmental factors just facilitate or sort of spur on the development of renal cell carcinoma. we will look at pathology a bit like urologists, not like pathologists. We just mention things that interest us. In macroscopy, and this picture that you see here is our patient that we reported on in the earlier part. I mentioned that we reported a case of renal cell carcinoma in pregnancy. So we clean up that specimen, gross specimen, and you can see it here. And so you see and it's always fascinating, and I share this particular picture all the time, that the renal cell carcinoma is clearly polar, just at the upper pole or the lower pole, particularly the sporadic type, and it's unifocal, and as it's encapsulated as well. The capsule is usually, of course, a pseudocapsule. And then it appears brownish, as you can see here. Of course, for the hereditary type, they're usually multifocal, bilateral, and do not, they could occur at any part of the kidney. Now, in terms of microscopy, now the histologic subtypes have been described, and they are all based on descriptive pattern as seen by the histopathologist when they look at the slides sent in from the kidney. So you have the conventional type, which is the commonest. 70 to 80% of all renal cell carcinoma are, clear cell or the conventional type. Now, what do they describe? They just look at the process of preparation of the slide and see that the cytoplasm washes off at a certain point because they contain a lot of cholesterol and cholesterol esters and lipid. And so during the preparation, the cytoplasm do not stain, and it makes it clear. So the cytoplasm is clear. So they describe it as clear cell. And so you basically see just the basophilic nucleus being stained, in the pattern. So that is a clear cell type. This is the commonest type, and this has the worst prognosis. It's really vascular tumor, and then we have the chromophilic. Now, chromophilic, just again, histologic description. If you look at the literature, and it just means that the cells, the cancer cells in this pattern, which is the second commonest pattern, it just loves dye. So it picks up the basophilic or eosinophilic dyes, and so it's described. And they also describe them in papillary, of course. So it is papillary in pattern or tubular in pattern, right? When you look at it under microscope. And then, of course, the chromophobic. The chromophobic type hates dye, doesn't stain right from the beginning. Unlike the conventional ones that pick up dye and is washed up during the process of preparation, this particular one doesn't pick up the dye at all. And so it hates dyes, chromophobic RCC, coming in at 4 to 5% of all RCCs. Then, of course, you have the collecting duct. Now, I should have mentioned that most of the renal cell carcinoma come from the proximal convoluted tubules. But, and this has been the traditional thinking. But now, the distal ones, the collecting duct tumor has been found. And this is based on immunohistochemistry, examination, which constitutes just about 1%. And once you are not able to put it in any of these described typical pattern, then it is described as unclassified. What is also described as the sarcomatoid pattern. But any of these histologic pattern could have a sarcomatoid component, and it just histology description, and it suggests more aggressive nature of any of these histology pattern. In terms of grading, the traditional and historical grading method, brought on by Foreman, 1982, is the Foreman nuclear grade. We use the nuclear size, the nucleolus appearance, and the shape of the nucleolus to describe or to grade the tumor. And this was, upgraded or looked at again by the Amin and his group, and the international group is Society for Urologic Pathologists, headed by Amin, and they look at it and they felt that it is simpler to just go back and say, well, it's well differentiated, whatever the pathologist wants to describe. well differentiated, moderately differentiated, and of course, so the 4-grade system which we are used to, are there. Of course, if it is well differentiated, we are clear about the fact that it is not so aggressive, and if it is poorly differentiated or anaplastic, we know that it is really aggressive tumor. So the grading system, unfortunately, do not apply to all histology pattern. It applies just to red clear cell type and the papillary type. But again, fortunately, for us to get a grade, of course, I mean, the clear cell pattern is the commonest. So we usually almost always get the grade. Now, this histology picture, this pattern is the clear cell pattern. And this is the patient, again, that we reported that had malignant tumor RCC in pregnancy. In terms of spread, most of the spread is direct. To the capsule, it ruptures the capsule and is limited by the gyrus fascia. It goes again very peculiar for clear cell cancer RCC. It spread, it sent tumor thrombus to the renal vein, and then IVC, sometimes extending to the atrium. This pattern, we see it once in a while when we operate on patient with this problem. Of course, the spread through blood to distant metastasis and regional lymph node. The commonest site of distant metastasis is lung. It's common in about 75%, right? And then, of course, it can spread to other. And so the staging, we do know it's early or advanced. If advanced, it will be locally metastatic. And the TNM classification of RCC is the most accepted. Of course, we've used the Robson's classification in the past, but it had its drawback. And so most persons, for uniformity, sticks to the TNM classification. It's something we should not just cram, but we should also always have it in a consulting room to make reference to be able to classify a tumor, because the classification has bearing to the management of the patient, not just management, the prognosis of the patient. And that would end my talk on the epidemiology, etiology, and of course the pathology of renal RCC. Thank you, sir.
Done.
Professor Anas is around. So, Professor Anas, can you unmute yourself? I've enabled you to unmute yourself. Professor Anas.
Okay, thank you very much. Good evening, ladies and gentlemen. I'm pleased to have the opportunity of joining this important webinar and to speak about the roles of interventional.
We can't hear you.
I think there's a problem with his internet where he is.
Okay.
Let me send him a text.
He's at the airport. He has gone off.
Okay.
Professor Al Hassan, maybe you may wish to carry on. He has gone off. Maybe he has a problem with the internet where he is.
Professor Al Hassan, are you there?
Yes. Professor Al Hassan, please don't unmute yourself again. If not, you'll be having
You don't mute yourself again.
Sorry, I'm trying to unmute you. Okay, Ismaila is back. Anas is back.
So can you hear me now?
Yes, I can hear you. Go ahead.
Yeah, we are going to restrict the presentation to 10 minutes, isn't it?
Yes, go ahead. Professor Anas, we are still on.
Screen at the moment.
Okay. Yes, we can
All
see
right.
your screen.
All right, so thank you very much.
Go ahead, we can see your screen.
Can't see a screen.
We are seeing your
So as
screen.
we are saying, radiology is helping the care of renal cell carcinoma through confirmation of. Let us quickly see the cytoreductive of the tumor pre-op or as a.
You can't hear him at all. Can you hear him?
No, where he is not so good, so maybe you can leave it.
I'll talk to him in a moment. Is Sani Alasan back on?
Yes,
Yes, I'm on.
it's on.
Sani, we have to tell him because we're not able to.
What I suggest, if he has his slide, he can just send it to us.
We have the slide. But
Okay, so
the audio is a problem.
the audio is a problem. Okay.
because if you can't get him, he's in the airport.
Good evening, sir. We're not able to hear you at all. We're not hearing you at all, at all.
So what I suggest,
Okay. You should. If don't mute yourself again. It says you can. Please, can you unmute him? He says he's muted.
Okay.
Can you unmute him? He says he's muted.
I'm looking for him now. He's not there.
So, I think you're actually not online
He's not there.
because you left. I can see. It says you have left.
Yes, he should rejoin.
I think you should relocate. Just relocate and then let me know so we can put you back on while somebody else presents while you're doing that.
Maybe we'll listen to Takure while he's getting himself.
Okay,
He's
just
back.
relocate.
He's back.
Okay,
Let me see.
Okay, it says you're back. It says you're back.
So unmute yourself.
Unmute yourself now.
Okay.
Yeah, we can hear you now.
You can hear me? All right.
Yes.
Yes.
to carry on. Quick 10
Okay,
minutes.
so
Not
let me.
sharing your screen again.
Okay, I will share the screen right now. You can see the screen.
Yes.
Yes.
All right. So we are talking about tumor ablation as part of the cytoreduction therapy. And this tumor ablation entails raising the temperature of the tumor to induce necrosis. And this is done by use of microwave, radiofrequency ablation, cryo ablation, and so on. All these have their advantages and disadvantages, but the key message is that this is applicable to early stages of tumor, which is less than 3 centimeters, and we can achieve total destruction of tumor cells, and so that we preserve the kidney as much as we can. And this is done with the help of ultrasound and OCT guidance, and they usually by the disposable probes, which after the procedure you can dispose it, and the outcome is really promising from the initial investigations so far. Well, the other aspect of tumor of cytoreduction
I hear you again.
Renal hematomas and other
chapters already.
And other hypervascular tumors.
Prayed with them. I said you should pray with them.
Okay. And can you hear me now?
Yeah.
Okay. So in terms of renal artery embolization, the RCC, the renal artery embolization entails cannulation whole purpose of inducing ischemia. This has been improved with the new advancement of chemotherapeutic agents, which will now be combined together with the embolic to do what is called chemoembolization. And this a preoperative infarction of renal tumors prior to nephrectomy has been proved to be useful, and also most so decreasing the vascularity to allow legs to reduce the intraoperative blood renal artery embolization. Most centers use give prophylactic antibiotics. From the same affected key like nephrostomy and or other drainage tubes should be flushed thoroughly, either with saline, and some people use antibiotic to flush them, and then they obtain consent. And what is important technically is the vascular access. The vascular access for renal artery embolization commonly is through femoral artery, but at times the femoral arteries may have issues like atherosclerosis, especially in elderly, and some of these patients you may have to go for other alternative arterial access such as axillary artery, brachial artery, or some use radial artery. And you require long guide wires, longer catheters, and which are technically cumbersome to use. So the arterial access is using the Seldinger technique, and we use the vascular access sheet to secure the access. The next is to do a flush iotogram, and the iotogram is to obtain the vascular, to define the vascular anatomy of the abdominal aorta. And that's very important because patients may have anatomic variations, presence of accessory renal arteries, and it may not be surprising to find that the tumor is being supplied by accessory artery to the tumor for embolization. Thereafter, we select the renal artery supplying that particular kidney of interest before we advance wire to use the selective catheter and deliver the embolic agents. And is to decide whether to do selective embolization or total embolization. Selective and super selective catheterization of segmental artery supplying the tumor is desirable. And this is especially if we are aiming at preserving a healthy kidney within the ipsilateral to the side of the tumor. And if at times this might not be feasible and may require the total embolization of the entire artery, and if the patient is to have a total nephrectomy. And some few examples from a hospital, which we did some years back, and especially this is, I think, our first patient with 83-year-old man with the right RCC with the infiltration of the vena cava and hematuria, and he has also systemic hypertension and had in the past history of hemiparesis from thrombotic stroke and necrotic center, and also some lymph nodes in the para-aortic region, compression and infiltration of the vena cava. The patient had selective embolization through the right femoral axis, and picked angiogram of the aorta, tumor with the abnormal vascularity, compressing and displacing the aorta. You can see the way it's stretching the renal artery on that side. So following so decision was made based on the earlier CT scan to go for total embolization. We can see the embolization coils within the treatment angiogram, showing total devascularization and these are the other post-treatment angiograms. Follow-up, the patient had total devascularization of the involved kidney, although he had a very acute rise in blood pressure, which sometimes is seen as an evidence of because of renal artery occlusion. Hello? Yes, sir. Okay, so on ultrasound, the mass showed reduction in size, and on application of Doppler, there is no absent blood flow into the tumor, on that side, a weak serial follow-up. The second case is a young lady, 20-year-old, with rapidly growing flank mass and hematuria and general body compressing the stomach and the spleen and displacing the bowel loops, and also compressing on the aorta. So she had a huge tumor. Yes, you can see the dense tumor blush within the kidney substance and placement of the aorta to the right side. And so the patient had coil embolization, margin of coil. So that's why it is recommended for the procedure to be as distal as possible, so that you don't give room for coil to migrate to undesirable destination. So this coil migrated down to the femoral artery, and it has to be retrieved back using a retriever, and later removed via the coil. Subsequently, the tumor showed no evidence of blood flow on follow-up. So from this, the renal artery embolization is safe and is tolerable, and complications to reduce the symptom of patients, and will potentially improve subsequent surgical outcome in patients who are fit for surgery, while for those symptoms and the patient may have a relatively better quality of life. And other apparently benign tumors with high also benefit from renal artery embolization. And we hope very soon this will be popularized in the country for our patients to benefit from these procedures. I sincerely thank the organizers for this webinar, for opportunity to speak, and I apologize for the intermittent interruptions of the net. Are there questions? Or comments related to the presentation?
Hello?
Yes, we can hear you.
I think these questions, people can post questions and they can be answered later since it's
okay,
on
sir.
transit. It's at the
All right,
airport.
sir. Thank you.
Yeah.
Okay. Thank you very much, sir.
Okay, stop sharing your slide, please.
Yes. Safe journey. So the next person is Tapure.
Hello. I've admitted you before. Go ahead. Let me try again.
Can you see my screen?
Yes.
Yeah, so I'll be discussing the clinical presentation and evaluation of patients with renal cell carcinoma. I bring you greetings from Ibadan. It would be nice to start with the surgical anatomy of the kidneys, and then we go to the relevant physiology. This will give us a better understanding of how patients with renal cell carcinoma can present. In relevant anatomy, the kidneys are paired organs that are found in the retroperitoneal space, anteriorly bounded by the peritoneum and posteriorly by the posterior abdominal wall. The kidney itself is encased in the dorsal fascia with a cushion of fat between it. The dorsal fascia encloses the adrenal gland with the kidney. A cross section of the kidney shows the anatomic the blood vessels to the kidney, where you have the renal artery and the renal vein draining the kidney. The renal artery follows the segmental supplies to the kidney, and we have the interlobal arteries, the aqueous arteries, and the cortical blood vessel. The kidney essentially consists of the cortex and the medulla. The cortex is where you find the functional units of the kidney, and the medulla takes the collecting dust to the minor calyces, where the where the urine produced is being excreted. Now, the importance of this blood supply will explain why patients with renal cell carcinoma do present first with hematuria. Now, looking at the surgical physiology, the kidney has two essential functions, which are the endocrine as well as the exocrine function. The exocrine function includes the production of renin from the juxtaglomerular cells, erythropoietin from the renal pericyte or myofibroblasts, and the ability of the kidneys to produce the active component of vitamin D, which is important in calcium metabolism. Now, renal cell carcinoma originates from the renal cortex in most cases. That's from the proximal convoluted tubules, and about 80 to 85% are primary renal cell carcinoma. This is the anatomy of the juxtaglomerular area, where you have the proximal convoluted tubules. You have the macular denser cells, the juxtaglomerular apparatus, and the juxtaglomerular cells that produce renin. What does the renin do? Renin that is produced in the kidney converts the angiotensinogen to angiotensin 1, which is a vasoconstrictor, and further conversion of angiotensin 1 to angiotensin 2 increase the ability of the kidney to regulate absorption and control blood vessels. The clinical presentation of patients with renal cell carcinoma can be described in 5 ways. There is the asymptomatic way, which is the commonest way they present in civilized environments. However, we do have the symptomatic presentation, in which case the patient can present with symptoms like hematuria, flank pain, weight loss, and abdominal swelling. Incidental presentation is found in 25 to 30% of cases. And usually this is discovered when a patient is asked to do an imaging study for different reasons. This CT scan, this coronal CT scan shows a patient of ours who had a lower pole incidental renal cell carcinoma that was locally advanced. And what happens in patient who had incidental renal cell carcinoma who do not present, it progresses to the localized disease and can also progress to advanced or metastatic disease. The localized disease are the symptoms that I've mentioned, and they can also present with laboratory abnormalities. And when they present laboratory abnormalities, we term that as the paraneoplastic symptoms or signs. The advanced disease may present with the classical triad, which occurs in about 10% of cases, and the distant metastasis to the lungs, to the liver, to the bones, and to the anterior abdominal wall, where you can have cutaneous manifestation. When they present to the lungs or to the chest, the patient often have a history of chest pain, difficulty with breathing, and hemoptysis. When they present to the lung bones, of course, they have bone pains. And when they present to the anterior abdominal wall, can have cutaneous nodules. This is the classical triad where the material is found in 40% of patients, and you can see this patient who has a flank mass, a very huge left-sided flank mass. It's found in about 25% of cases, and then flank pain in 40%. What are the paraneoplastic symptoms? The paraneoplastic symptoms can be divided into hematological, biochemical, systemic, musculoskeletal, and others. In the hematological, patient can present with anemia in the absence of hematuria. They can also present with thrombocytosis or erythrocytosis. The biochemical presentation is that of hypercalcemia that will be discovered from the blood sample taken. And for the first time, a patient who has a renal cell carcinoma can actually present with hypertension and fever. Those who present with fever is due to the presence or release of interleukin 1 into this circulation. Polymyalgia rheumatica is also musculoskeletal way in which the patient may present. Of course, Stopper syndrome is a reversible hepatic dysfunction. Some of our patients who present with that, this table shows 7 of our patients who present with paraneoplastic manifestation. These patients have high level of alkaline phosphatase, they have high level of aspartate and alanine transaminase, and a reduced protein and albumin level, which are things that are actually accompanies patients who have a Stopper syndrome. It has also been reported that some of these patients can present with jaundice. There are case reports of patients who are presented with jaundice. Of course, other manifestations will include the left-sided varicocele. Those who present with left-sided varicocele is due to an obstruction or extension of the renal, of a thrombus into the left renal vein that affects the drainage of the left testicular vein at right angle to the left renal vein. Cachexia is another paraneoplastic way patients may present. Those who have cachexia usually have a low albumin level, they have weight loss, anorexia, or malaise. What do we see on physical examination? The physical examination is expected to identify some of the things that were mentioned in their symptoms. 30% of patients present with metastatic disease, and we need to evaluate the systems where the metastases are. Examination of the chest may reveal reduced chest excursion, may show tenderness if the tumor has spread to the ribs, and if the tumor has spread to the anterior abdominal wall, we may pick subcutaneous nodules. For the liver, we will be able to appreciate hepatomegaly, and for central nervous system, some of the patients will present with hemiparesis. There was a case report from Ibadan by Shibuzo et al. Of type 2 papillary renal cell carcinoma that spread to vulvovaginal area, and that was how the patient actually presented. We mentioned left varicocele in males, very important in males, and when we suspect hypertension from clinical findings, we should also know that patient may have renal cell carcinoma. What are the differential diagnoses in the patient with renal cell carcinoma? We consider angiomyolipoma, which has the components of blood vessels, lipids, as well as fat. We also have oncocytoma, it's a benign lesion, but it can be a very big mass and may be difficult to differentiate from renal cell carcinoma except on histology. Renal adenocarcinoma may be difficult to differentiate these also in patients who have a small size renal tumor, like tumors less than 4 centimeters. Of course, renal cyst can be a differential diagnosis of renal mass, and we use the Bosniak classification. The type 4 is more in keeping with the patient with renal cell carcinoma. Renal infarction may present with a renal mass, and sarcomas in the renal region are also possible differential diagnosis. Now, in evaluating patients with renal cell carcinoma, we would like to use this evaluation to arrive at a definitive diagnosis to also aid the staging of renal cell, particularly for patients whose tumors are spread to the renal vein, inferior vena cava, or the lymph nodes. And the imaging studies can differentiate cystic from solid masses. Laboratory studies are essential in identifying or establishing the presence of paraneoplastic syndrome. And like I said, the imaging studies will help us to stage the disease and determine appropriate treatment and plan, as well as prognostication of the disease. The laboratory studies of importance is the liver function test. In the liver function test, an abnormal level, high level of aspartate transaminase, alanine transaminase, or alkaline phosphatase may suggest paraneoplastic syndrome. And if we found in the blood test a high calcium level, it should increase the suspicion of paraneoplastic syndrome. Full blood counts may confirm the presence of anemia, may confirm the presence of thrombocytosis or thrombocytopenia, which are features of paraneoplastic syndrome. However, patients who have urothelial carcinoma, cancer from the renal pelvis, urine cytology may be important. In the past, the imaging test of choice was intravenous urography, but because of the low sensitivity and specificity, this has now been downplayed and is not done commonly. However, we can still mention it for historic reason, that the findings in the intravenous urography will show a filling defect. On the right is a normal anatomy that we find in the intravenous urography, the major calyx and the renal pelvis, well outlined, upper, middle, and lower. In the slide on the left, you can appreciate that there's a filling defect, distortion of the calyx in the upper and the lower side, and this suggests that the renal tumor may occupy the upper pole and as well as the middle pole. That's the inference that we usually get when we use the intravenous urography. But other imaging studies that are now being done commonly is the abdominal ultrasound, which is cheap and affordable. The abdominal ultrasound will show a huge heterogeneous echogenic mass. In this slide, this is one of our patients who has a huge right-sided renal tumor, and you can see this huge echogenic mass. The CT scan is usually done in 3 views: the sagittal view, axial view, and the coronal view. The sagittal view in this case shows a right-sided huge renal tumor. These are the kind of tumors that we have, and as it is relatively encapsulated, as mentioned by Apayak in the initial presentation. This is the axial view of the same patient with a huge left-sided renal tumor, and that's the coronal view of the same patient. When we suspect metastasis, or if you have a patient who cannot tolerate contrast, then we may have to use a magnetic resonance imaging study. And magnetic resonance imaging study we delineate the venous involvement, renal vein thrombus, and the thrombus extension to the inferior vena cava. Patients who have symptoms that are referable to the chest, the chest X-ray will identify the cannonball secondaries, which is classical for patients who have metastases to the chest. Of course, bone scan will reveal osteolytic changes if they have metastases to the bone. And then we can also do this brain CT scan for patients who have a renal tumor metastasis to the brain. This is a table of symptoms of clinical presentation from studies that have been done in Nigeria. The total number of patients is demonstrated here. We have more of the female preponderance in this study. Female preponderance in this study, although worldwide is male that are commonly affected. Hematuria is also the commonest way patients present in our environment. We have in a study, Tijani et al., majority of their patients actually had weight loss. Majority of the patients had hematuria. And then we have one study from Ibadan that shows flank mass. All the patients had flank mass. In the classical triad, the highest recorded classical triad case was by Apayak et al., where there are 45.5% of the patients presenting with classical triad. Incidental finding is not very common in this environment. IIG reported a low incidence of 1.6% of incidental renal cell tumor, and Ahmed et al. Reported 11.8 in Zaria. Of course, Alakor in Ife reported approximately 6% of tumor. Anemia is also found in some of the studies, metastases as demonstrated. In the evaluation, the common imaging studies that we use in this environment is abdominal ultrasound, CT scan, and intravenous urography. We rarely use magnetic resonance imaging study, except that reported by Salakor et al. These are my references. Thank you.
Very good. Okay, who is the next presenter?
Pani.
Tani.
Sorry, Ugumba.
Ogumba. Okay. Okay, Ogumba. Can you?
Yes, sir.
Can you start? Is it Aji or Ogumba?
It's Ugumba is starting.
Okay. Okay. So Ogumba, 10 minutes.
Okay. Good evening, everyone. My remit this evening will be to discuss the surgical management of renal cell carcinoma in the next few minutes. Okay, so by way of introduction, we've had the epidemiology. This is a tumor of concern to urologists, and it occurs in these figures and also presents with significant morbidity and mortality. The global figures and those from Africa are shown. In terms of presentation, we've had the series from evaluation, but I've just put this up to emphasize the fact that quite often in these parts, we're dealing with stages T3 and T4, and this is spread across all the papers coming out of Nigeria. And that informs, of course, the management that you offer. Now, what are the clinical scenarios? Renal cell carcinoma could occur essentially in three forms clinically. Is either we're dealing with localized disease, is locally advanced, or is metastatic. And therefore, if we're offering or intending to offer surgical management, the aims would be those of achieving a cure in local disease or a complete resection of a tumor in local disease as a prelude to some adjuvant therapy, or one to achieve reduction of tumor burden in the setting of metastatic RCC, or we're looking to deal with an oncological emergency, perhaps intractable hematuria, bowel obstruction, or something of that nature. Now, what are the options for surgical treatment? They include these. The flagship of surgical treatment for renal cell carcinoma is a radical nephrectomy and remains the gold standard for the treatment. Of more recent interest is the partial nephrectomy or nephron sparing surgery, as increasing realization of the need to spare nephrons wherever possible, particularly in smaller tumors, became more obvious. And then you could have cytoreductive nephrectomy as a partner or collaborator with for metastatectomy. And then we could have tissue ablative therapies, which are put in blue because it's not really strictly surgery and has been spoken to as we've heard this evening. Now, these operations can be achieved by several techniques. The traditional or the oldest would be the open radical. We know that laparoscopic has been established as an option for offering a radical nephrectomy. More recently, the robotic option has come into play. And then for the partials, this could be achieved as laparoscopic, robotic, or open. Now, just a quick reminder about these are flagship operation. When we say the radical nephrectomy, of course, we know that we're speaking of an operation that has certain components. One is an en-bloc resection of the kidney with the perinephric fat, that is taking the capsule of Gerota with it. It used to include always an resection of the ipsilateral adrenal gland and lymphadenectomy. This increasingly might not make up a radical nephrectomy for reasons which I'll speak to in the following slides. Now, it's established as a proven and effective way of controlling local disease. The issues of adrenalectomy or lymphadenectomy, as the series began to emerge after the original operation was done, shows that it does not appear that there is benefit of performing these two components if on the modern axial imaging that are now available, they do not appear to be involved. That is the adrenal gland and lymph nodes. And therefore, they tend to be left out if the tumors are not on the upper pool for the adrenal gland and so on. Of course, it's associated with certain factors, which is the morbidity of the incision. That, of course, goes with a longer recovery time. And then you're losing an entire kidney with the associated nephrons. And there may be some issues of a shortening of the time or a propensity in some patients to progress to CKD if they are prone to it. What would be the indications of this? Usually when there's a large tumor size, as we see often, a central location in the setting of a normal contralateral kidney. When there are multiple ipsilateral renal lesions, if you have a venous tumor thrombus, you would require that. And then if you're doing a cytoreductive nephrectomy in the setting of metastatic disease. The second or the next would be if you're required to perform a partial nephrectomy, nephron sparing surgery, which basically is removal of the tumor with a rim of normal tissue, aiming to achieve a negative surgical margin. And of course, ensuring that there is limited morbidity or complications as a result of sparing that kidney. Now, there are some issues associated with this. Of course, the goal is to achieve local control of the tumor, oncological control, that is the primary purpose. But you want to achieve something else, which is sparing of nephrons. And therefore, it becomes important preoperatively to determine who gets what. And a clear attempt, a purposeful attempt at defining tumor complexity needs to be made. Recently, some nephrometry scores have emerged, beginning with that of Kutikov of the renal nephrometry scoring, which essentially looks at some criteria, including the radius of the tumor, whether it's endo or exophytic, nearness to the collecting system, location, and so on. Essentially, these are scored, and in addition with tumor size, helps you determine whether this patient is likely to do well if offered a nephron sparing surgery. In terms of determining the outcomes of this, it is usual to consider what is called a trifecta of outcomes, which is achievement of a negative surgical margin, a warm ischemia time, ideally less than 30 minutes, and the complications, Clavien-Dindo, should ideally be less than 2 if you're considering a partial for a patient. And the indications, some of the usual suspects are, as I've shown them, usually when they are less than 4, but this is not by all means a mandatory thing. It can actually be done for larger tumors, but these criteria are individualized. If a patient has a bilateral RCC without metastasis, is a candidate. If he has concurrent disease, diabetes, hypertension, and so on, or anything that will predispose him to CKD later, then it should be considered for this patient. A third component or arm of these surgical therapies will be the cytoreductive nephrectomy. And essentially, this speaks to the removal of the kidney as the primary tumor in the face of metastatic disease. So when this is being done, it's clear that the goal is not a cure, but you're essentially aiming to debulk this tumor or reduce the tumor burden in the hope or belief that you could induce positive outcomes with adjuvant therapy, or in the older era or the cytokine era, that they could undergo spontaneous remission, which is actually what led to the consideration of some of this. The mechanisms of this remain unclear, but some of the postulated mechanisms are those I've shown, that if you take off the tumor, then you remove the immunological sink where some of the active immune cells tend to hide, so to speak. But we need to be reminded that these cytoreductive nephrectomies are associated with significant morbidity and mortality, because of course, these patients are not in the best of shape. And therefore, serious consideration needs to be given to whether they should get these operations or not. In other words, are they operable? They are associated with some issues like anemia and so on. So prior to a few years ago, it used to be something sorted out with gut instinct, and there wasn't much data. But data has emerged now with some trials that address this issue of patients who have metastatic disease and surgery is being entertained in the era of adjuvant therapies. And these two are important. The Camina trial essentially was looking at nephrectomies alone, or if you're giving targeted therapy alone, and whether the outcomes were different. The second was considering sunitinib with surgery or without, or deferred surgery and sunitinib with surgery later. And essentially what this spoke to was that there appeared to be positive benefit if these patients got adjuvant therapy first, responded to it before they had surgery. And therefore that speaks to the choice of these agents or this procedure, if you're intending to do it. If the adjuvant therapies are available, perhaps this patient should be tried on it and before they proceed to surgery, given the morbidity and mortality figures I've shown earlier. Most of what I've spoken on are encapsulated in these guidelines, which are from 2020 or 2019. And I've highlighted a few of them, which I'll just quickly go through in terms of sorting out the evidence for what to do or what not to do. So as I've highlighted, it appears that the evidence is strong to offer surgery aiming at cure if you have a localized renal cell cancer. You should probably offer a partial if a patient has a T1, and you should not perform an ipsilateral adrenalectomy if there is no clinical evidence of invasion. The others are as I've shown. So if you're considering this operation or operations, the patients need to be evaluated. And what is it that we do, which is what we do every day in our practices? We essentially need to get a good history and do a physical exam, do the basic urine and blood work as I've shown. The value of calcium and the liver function enzyme series have been spoken to, so I won't repeat those. It's important to do a pulmonary function assessment, given the anatomy of the area we're going to, particularly if an open operation is being considered. It is useful to use low technology or cheap things to improve respiratory function. So we need to find out whether this patient has a cough, what's his respiratory function, does he have chronic obstructive airway disease, and perhaps some prehabilitation, as is becoming popular now, needs to happen with some incentive spirometry so that they're able to breathe effectively and have adequate lung expansion before they get these interventions. If they're taking blood thinners, they need to be stopped. We need to screen them for bleeding disorders. The purpose or the value of axial imaging cannot be overemphasized. That has been discussed. And ideally, a patient being planned for a nephrectomy of any sort should have a differential renal function assessment so that you determine what you're going to be dealing with post-operatively. Now, in the metastatic setting, it's important also to be more thorough or critical in the way these patients are evaluated in terms of determining whether are they actually going to come out of these surgeries worse or better. There are criteria out there that have been developed, which include the Memorial Sloan Kettering Cancer Center criteria, the HEN criteria, which essentially look at about 4 or 5 items, including Karnofsky score, enzyme studies, and all that, essentially trying to prognosticate what this patient's outcome would be if they are offered surgery with metastatic renal cell cancer. It's useful to have them and use them in our practices. And even if we forget or don't do that, the good old end of the bedogram for an experienced clinician is always useful. If you pause for a minute and assess this patient critically and ask yourself, really, what is this patient going to benefit from this surgery? What am I trying to achieve? Or maybe ask it in another way. Can I get this patient off the wards in a week after surgery? Probably if the answer to some of those things are no, then we need to reconsider what it is we want to do. So to the main business, the access for these operations, whatever platform is being delivered through, essentially will follow what I've just shown. So if we're doing an open, the accesses are either flank or anterior, which are largely extraperitoneal or transperitoneal. If you're doing the lap or robotic, they can be transperitoneal or retroperitoneoscopic. The incisions are as I've shown. For the laparoscopic and the robotic, usually the camera ports will come probably at umbilical level so that you're looking up to where the kidneys are. And then the accessory ports, the working ports, will come by the side using triangulation to get to where you're going to. Same things will happen if you're doing the flank approach. Now, how do you choose what to do? Some other considerations. If you're doing the supine, you may vary the tilt to table tilt or use a beam bag to elevate the loin and push the kidney up. If you're doing the lateral, adequate lateral spine flexion helps to push the kidney up. Other considerations would be the anatomy of the patient you're dealing with. If his tumor is at the poles, upper pole, lower pole, then you probably can go with a lower incision or a higher one. What side are you dealing with? So if you're on the right and left, are there peculiarities you need to consider? The size of the patient and body habitus are quite important. And for these For people who are morbidly obese or very large patients, there is some significant benefit for the flank approach, because when the table is tilted, the panniculus tends to drop away, and then even the work of breathing from the anesthesia end is improved. At the end of the day, the surgeon preference will probably top the chart in terms of people generally do what they're comfortable with and gives them good results. Okay, so to the surgery proper, which we are all familiar with, but I'll just go through some key elements or steps. Whatever access we use, we need to do a perirenal or retroperitoneal space dissection to define the kidneys where they are. We need to define the aorta or the cava, depending on what side we're coming from, and then proceed to identify the renal vessel, the renal vein, the artery. And I need to emphasize that part of the imaging that needs to come before now, I realize that sometimes this is not done, should be, every effort should be made to define the vascular anatomy of the kidney. So are there accessories or aberrants? Okay, we bear in mind the issue of the lumbar veins, which I'll speak to. So when we define these structures, identify the gonadal vein, and then we proceed to a ligation. Usually this ligation should take the artery first. And if you have a single renal artery, that should lead to a decompression of the vein immediately. And then the ureter. If you're dealing with a thrombus, as you defined preoperatively, there needs to be a more extensive caval dissection so that you can get some proximal and distal control. As this is being done, we need to remember these fellows. The lumbar veins appear very small, but they are easily torn and can cause some difficulties when they are disrupted. A tumoral thrombectomy can be part of this procedure if you're dealing with a T3. But if it's not, at the end of the devascularization, you complete the mobilization of the kidney and excise it and proceed to closure. I've spoken about the adrenalectomy and the lymph node dissection, which, if there is no pre-operative evidence, largely most series do not include this as a standard because it's shown that it doesn't improve the outcome, oncologic, overall survival, and so on, and adds to the morbidity of the surgery. Are there complications we could expect? Yes, it's a surgery. If we recall that 1/4 of the blood supply of the cardiac output goes to the kidney, so hemorrhage should always be borne in mind. Hilar vessels may slip, which is why it should be standard practice to ligate them in continuity before dividing. We need to remember the issue of accessory arteries. I've talked about lumbar veins. Very rarely there may be, very rarely there may be an SMA injury if you're dealing with a large left-sided tumor. We remember the proximity of the left renal vein to the SMA. The anatomy can be distorted and this may be injured, so we look out for that. The duodenum is very well known for its behavior of being unforgiving when it is injured. So when we're working on the right, we need to make sure we coccorize properly and take it out of the way. The pancreatic tail is something to look for. Ileus is a problem, particularly with the open operations, and the pain and analgesic requirements, flank bulge, and scar issues are clear problems with the flank, with the open operation. The flank bulge, particularly with the flank access, if you divide the nerves, probably it won't happen with an anterior approach. What are the outcomes? The outcomes, the series generally say the same thing. Even the meta-analysis say similar things, that the outcomes are similar in the open and the laparoscopic in terms of overall mortality and cancer-specific mortality. But for intraoperative complications and post-op complications, reduction in analgesic requirements, faster recovery, and all of that, of course, the laparoscopic will top it. Most of the outcome measures are encapsulated in this study, maybe if you're interested for further reading. And essentially what it says is that in patients undergoing radical nephrectomy for RCC, the robotic appears to offer some key advantages compared to the open, which is the usual things we expect. Compared to the laparoscopic, the robotic offers similar surgical outcomes but at higher costs. And the rest is as I've shown. So to conclude, I'll conclude by saying that surgery remains a key pillar in the management of renal cell carcinoma, considering the fact that this tumor is radio-resistant, and until the emergence of the adjuvant therapies was and still remains the key fulcrum for managing these patients. The available interventions will continue to involve regarding the following items: choice of operation or technique, and who gets what. If we look at the emerging things now, we see that a greater portion of patients are beginning to get nephron sparing surgery, and the criteria appears to be expanded. The timing of the surgery are spoken to in terms of in the metastatic setting. Should the patient get surgery first before adjuvant therapy or after? There are also issues of tumor size and what happens. And then emerging technologies will continue to impact all of this. I thank you very much for listening.
Well done, Ogumba. That was a very nice presentation. Now the next person is Professor Sani Agi, who is presenting alternative treatment, immunotherapy, and others.
Good evening, senior colleagues and colleagues. I'm going to talk on the non-surgical treatment of renal cell carcinoma with emphasis on drug treatment as systemic treatment. I intend to discuss following this outline. I will first introduce the topic and then discuss about the available modalities of treatment in non-surgical, ranging from active surveillance, radiofrequency ablation, cryo ablation, stereotactic ablation, and then the drugs, under which you have chemotherapy, immunotherapy, and then recently targeted therapy. And then I will talk about the local challenges of managing drug treatment of renal cell carcinoma in our environment, and I then conclude. Renal cell carcinoma is the third urological cancer, representing 3% of all cancers in women and 5% in men, as has been stated by other speakers. 30% of patients are metastatic at diagnosis. And even among the 30% that present with early disease, they tend to metastasize during follow-up. So clear cell carcinoma represents the vast majority, accounting for more than 75% of cases. Other histological types include papillary cell carcinoma and then chromophore renal cell carcinoma. Clear cell carcinoma are hallmarked by frequent alteration of VHL gene, which is a tumor suppressor gene that is leading to angiogenesis through transcription of gene regulated by hypoxia-inducible factors, such as vascular endothelial growth factor. Renal cell carcinoma are known to be resistant to both chemo and radiotherapy. It is important to note that drug treatment is mainly reserved for metastatic diseases. So the available non-surgical treatments are active surveillance, radiofrequency ablation, cryoablation, stereotactic ablation therapy, and then the systemic therapy using drugs. Active surveillance is an important form of therapy in patient with renal cell carcinoma. It is indicated in patients that are elderly and have comorbidity, in whom we found the cancer incidentally. And these cancers usually have to be at least less than 3 centimeters before thinking of active surveillance. And active surveillance entails initial monitoring of the tumor size by serial abdominal imaging, such as ultrasound scan, CT scan, MRI, with delayed intervention reserved for only tumors that are showing clinical progression during follow-up. Watchful waiting, however, is reserved for patients whose comorbidities contraindicate any form of treatment, and they do not require regular follow-up with imaging, as occurs in patients on active surveillance. Other indications for watchful watching are advanced renal cell carcinoma with fewer adverse prognostic factors, low burden of tumor, limited organ metastasis, and absence visceral involvement, and also patients that are asymptomatic. So radio frequency ablation can be done either via laparoscopy or percutaneously using image guidance with CT scan or MRI. It has been found to have a success rate of 34%, 94% for patients with T1A tumors, and 81% in patients with T1B tumors. 5-year overall survival rate was found to be between 73 to 79%, and 10-year disease-free survival was found to be 82%. Cryoablation is another form of minimal therapy in patients with small tumors and comorbidities, and is reserved for only small tumors, that's tumors with T1A. Local recurrence was seen in 7.7% of patients with T1A, and 34% of T1B will have local recurrence, as shown by some studies. So disease progression increased by 32% with each 1 cm increase in tumor size on those patients that undergoes cryoablation. And the progression-free survival rate was 6.7% at 12 months. Only 45% of patients remain disease-free at 2 years. So that indicates that cryoablation is not as effective as radio frequency ablation therapy. How about stereotactic ablation? This has been emerging as a treatment option for medically inoperable patients, also with localized disease, T1A and T1B. Though it's a new treatment option, the results are encouraging, with local control rate of 97%. However, grade 3 to 4 toxicity occur in 1.5% of patients. Other ablative techniques that are still under investigation or are not routinely done include microwave ablation and then now high intensity focus ablation. With the other ablative techniques, the 5-year progressive rate was found to be 3.2%, while 4.3% of patients will develop distant metastasis. So these are the non-drug treatments, alternative to drug treatment in patients that have small tumors, those that cannot withstand surgery. How about chemotherapy? Renal cell carcinoma is known to be highly resistant to chemotherapeutic agents. Initially, drugs that were used include 5-fluorouracil, doxorubicin, and even the newer agents such as Zeloda, but no single agent demonstrated a response rate of more than 10%. Since they are non-specific for cancer cells, they have very high toxicity. So presently, chemotherapy has no role in the treatment of renal cell carcinoma. Next is immunotherapy. We all know that renal cell carcinoma is among the most immune responsive of all solid tumors. Historically, renal cell carcinoma used to be treated with cytokine-based immunotherapy using either high-dose interleukin, which was associated with durable complete response in only small subset of patients. And then interferon alpha is other drug that has been in use over the past 20 decades, before the past 20 decades. Over the past 20 decades, medical treatment of RCC has transitioned now from the non-specific approach, that's the cytokines, which other people refer to as the traditional immunotherapy, now to a targeted therapy against vascular endothelial growth factor, and now to a novel immunotherapeutic agent. So this picture will show the therapeutic biologic pathway by which the targeted therapy of renal cell carcinoma is used. If you follow the cursor, this is the tumor cells, the tumor microenvironment. And once there is stimulus because of any of the risk factors, so there will be activation of these tyrosine kinase enzymes. So there are basically 3 or 4 pathways through which the tumor will continue to progress by way of angiogenesis. One of this pathway is the mammalian target of rapamycin. So once this is stimulated by the enzymes, there will be what? MRI translation. And this MRI translation further causes expression of hypoxia inducible factor. And then this led to further transcriptional activation of the target genes, the hypoxia inducible factor target genes. And this will cause overproduction of the vascular endothelial growth factors, platelet-derived factors, and other growth factors. Then the other pathway is because there is abundance of VHL in renal cancers. So if there is any suppression of the VHL, this VHL will lead to, because of hypoxia in the tumor microenvironment, will lead to overexpression of hypoxia-inducible factor. This then also cause transcriptional activation of of the target genes, and also lead to overproduction of vascular endothelial growth factor and platelet-derived growth factors. And these factors will act on the endothelial cells and cause rapid angiogenesis. So in order to stop this progression of this disease, so the pathways that are currently in use are: one, we can block the MTO, that's mammalian target of rapamycin, by the use of drugs such as tocilizumab or everolimus. The other way to target, to arrest the progression, is by using drugs that directly block the vascular endothelial growth factors. And this is exemplified by the use of the carcinoma. These are monoclonal antibodies that are used. Then the other pathway is to block the receptors of the vascular endothelial growth factor. And this is where we have the first generation of drugs that are used in the treatment of in the treatment of renal cell carcinoma. So targeted therapy, therefore, we can say that in clear cell renal cell carcinoma, hypoxia inducible factor accumulation due to VHL inactivation results in overexpression of vascular endothelial growth factor and platelet-derived growth factor, which promotes neuroangiogenesis. So this then contributes to the development and progression of renal cell carcinoma. Several drugs have been approved by the FDA. This started as early as 2006 and are still in use. So example of these drugs that block the tyrosine kinase inhibitors includes sorafenib, sunitinib, pazopanib, axitinib, cabozantinib, and lebantinib. All these drugs have their various efficacies and also some toxicity. So treatment with this drug depends on availability and tolerability by the individual patient. Then we have the other group, which is the mammalian target of rapamycin inhibitors. So under this, we have tensorilimos, we have everolimus. Now, recently, we have what we refer to as immune checkpoint inhibitors. Immune checkpoint inhibitors are monoclonal antibodies. And what they do is they block the inhibitory T cell receptors. That's programmed cell death receptor 1, gene 1, or cytotoxic lymphocyte, which is PDL1. So example of drugs under this, we have anti-PD1, we have nivolumab, and pembrolizumab. And then we have the anti-PDL1 exemplified by ipilimumab, avelumab, atezolizumab. So this picture tries to support the use of these targeted care drugs as opposed to the older traditional immunotherapeutic agents. Most of these, in these studies, most of the studies use interferon as the comparator. The Mozart study of 2007 compared sunitinib, which is VEGF receptor antagonist, is compared with interferon alpha. And the median, the progression-free survival in this group, the median survival in months has shown that for the new drug, that's sunitinib, the median progression-free survival is 11 months, whereas the interferon is only 5 months. And the overall survival for the sunitinib is 21.8, while 0.8 is 26.4 and 21.8, with hazard ratio of 0.82. Again, another class of drug was used, that's bevacizumab, in 2007 also. So it compared combination of bevacizumab with interferon, and then interferon with a placebo. Again, progression-free survival in the newer drug, that's bevacizumab, is 10.2 months compared to 5.4 in the interferon group. So overall survival in this group is 23 months compared to 21 in the interferon group. So other drugs have been tested in order to justify the benefit of the newer target over the traditional immunotherapeutic agents. And this has not even considered the toxicity. So toxicity is another factor that is against the use of the older generation of immunotherapeutic agents. Now, the teaching has changed again. It kept changing. Now we're in the era of combination therapy. So clinical landscape of treatment for RCC is still changing. So recent studies have established the role of combining tyrosine kinase inhibitors targeting the VEGF pathway, and then combination with PD1 inhibitors or PDL1 inhibition. So this led to change in the first line of immunotherapeutic treatment for renal cell carcinoma. Initially, what we consider as first line drug is because of the agent as zilutinib, sunitinib, and co. But now with the combination, it has changed the whole scenario of treatment of patient with renal cell carcinoma. So combination therapy helps in overcoming resistance, because we know that one of the problem of this cancer cell, along the course of progression, they may develop resistance. So in order to delay resistance or to overcome the resistance, that's why combination therapy is now in place. So combination can be in the form of immune checkpoint inhibitor plus immune check inhibitor, or immune checkpoint inhibitor and vascular endothelial growth factor tyrosine kinase inhibitors. This picture try to justify combination therapy over single agent therapy. Several studies have been done. If you look at the Javelin trial group, they compared combination of avelumab plus axitinib with sunitinib. And this is a phase 3 randomized controlled trial in patients with clear cell renal cell carcinoma. And this was used as first-line therapy. And the overall survival in the patient with combination therapy is in 12 months is 86% compared to 83 in the patient with single agent, though the difference is not much. But if we look at the median progression-free survival in the combination group is 13%, 13 months versus 7.2 months in the single agent group. So overall response rate in the combined group is 5.2% compared to 2.5% on the patient that use the single agent. So complete response also is 3.4% versus 1.8 in the single agent group. Then we have the keynote study, which combine pembrolizumab, which is immune checkpoint inhibitor with axitinib, and this is also compared with sunitinib, also a phase 3 clinical trial, and it assesses on patients with clear renal cell carcinoma. Here also, the treatment is used only as first line. So overall survival in the combination group in 30 months is 60% compared to 47% in the single agent group. So if we look at the median progression-free survival in this group also, we can see that they survive for 15 months compared to 11 months in the single agent. And overall response rate was 593 versus 59.3 versus 3.7. Then we have the checkmate studies. The checkmate trial compared combination of nivolumab and ipilimumab. Both are anti-programmed cell death. And this is compared with sunitinib alone. And if you look at the overall survival, also in 30 months in this group, 60% in the combined group versus 47% in the single agent group. And then if we look at the progression-free survival also, is in this group, we can see that is 11.6 versus 8 months. And then overall response rate is 42 versus 49. So with this and other studies, you can see the justification that combination therapy is now the standard of treatment. It's far superior to single agent use. And based on this, now the recommendations from updated EAU guideline for the use of first-line treatment in metastatic renal cell carcinoma is as follows. So what they considered is first the risk stratification of the patient. So using the IMDC, that is International Metastatic Renal Cell Data Consortium. So this is a risk stratification which uses about 6 parameters and is stratified into favorable, which have 0, and then 1 to 2 intermediate risk group, and then 3 to 4, 3 to 6 poor risk group. So now, currently, by the EAU guideline, the standard of care as the first line treatment in patients with metastatic renal cell carcinoma should be a combination therapy. So one is combination of leronlimab, or which is PDI inhibitor, with cabozantinib, which is the TKI inhibitor. So in order to support this, there is level 1B evidence supporting this. It's either to use this combination, or we can use pembrolizumab and azacitidine as first line. You can also use pembrolizumab and lenvatinib. So all these can be used now, the standard now first line treatment according to EAU guideline. So however, if for any reason the patient cannot tolerate this drug, either because they have contraindications such as autoimmune disorders, or patients that have solid organ transplantation, or because they can't withstand the toxicity. So in that regard, pazopanib can be used as a single agent. How about for patients with intermediate and poor risk group? Again, there is no difference. The same combination can be used as first line. And then where there are contraindications or there is toxicity, and then cabozanib as single agent, or sunitinib or pazopanib can be used. So this is the current standard of treatment of metastatic renal cell carcinoma according to EAU guideline. Other factor that's considered apart from the risk stratification group in the treatment of this patient is to consider prior immunotherapy. Perhaps the patient have been on maybe the traditional form of cryotherapy. So if that is the problem, so what is the standard of care now according to the current guideline? Is to use any of the VEGF targeted therapy that has not been used before. Okay, then if they have used the TKI prior to, and they have developed resistance or something else, then any of these drugs can be used. That's nivolumab or cabozantinib. And if for any reason they have developed resistance or they cannot withstand any of this, then azacitidine can be used. So this is the current first line therapy according to the EAU guideline for patients with metastatic renal cell carcinoma. Still, there are other trials either ongoing or they have not been completed. So we'll not waste time here. So now, what factor do we consider before combination therapy? So one is
Please round up. We're taking a lot of
risk
time.
stratification, example using the IMDC risk profile. And then we consider the patient age also. Then we consider contraindication to any of the immunotherapeutic agents. And then, of course, drug toxicity. What are our own challenges here? We all know that generally our patients present late. That 30% of presentation with metastatic is more than that in our own environment. So therefore, majority of our patients may not benefit from surgery. They may benefit from drug treatment. And we all know that these drugs are very expensive. Our patients cannot afford these drugs. The other trouble is these drugs are not readily available. Even the earlier drugs, as azacitidine, are not readily available, and they are expensive. So this is a problem. So now I don't think we have the immune checkpoint inhibitors in this country. And then we know that we lack local guidance for treatment of most of the disease in our environment. So in conclusion, I would say that the treatment of metastatic renal cell carcinoma has radically changed over the past 2 decades. Initially, first-generation immunotherapy with cytokines was the standard approach, but of course with poor results. So development of tyrosine kinase inhibitors, mainly the VEGF receptor antagonists, largely improve both progression-free survival and overall survival. And the emergence of immune checkpoint inhibitors alone or in combination has shown a much better treatment outcome. I thank you for your attention.
Thank you very much. That was a very good presentation, quite extensive, and doing justice to immunotherapy for radical for renal cell carcinoma. So I think that's the last presentation, and I will just quickly take 2 minutes to summarize what the presenters have presented, and then we take a few minutes for questions. Now, the first presentation was by Dr. Apaya, and he presented the epidemiology of renal cell carcinoma, accounting for 3% of all solid tumors in adults. This is increasing due to better imaging. The etiology is not known, but environmental exposure to chemicals have been implicated. And 7% are bilateral, otherwise they are unipolar and unilateral. 70 to 80% are clear cell carcinoma, and the grading system is restricted to mainly clear cell and papillary carcinoma. The Fuhrman nuclear grading 1 to 4, and then there is WHO consensus. And next, we had a presentation from Professor Anas Ismail, the use of interventional radiology in the treatment of renal cell carcinoma, mainly that of cytoreductive therapy for kidney preservation, especially in bilateral tumors, renal artery embolization to infarct the renal tumor, which may be selected prior to nephrectomy or in poor surgical risk patients or for palliation. The complication being that the coil may migrate. And then we had a presentation from Professor Takure, clinical presentation, a lot of them being asymptomatic. 40% may present with hematuria. There are 3 modes of presentation: asymptomatic, locally advanced, and in 30% with metastasis. They may also present with paraneoplastic symptoms, mainly related to tumor effects, such as high serum calcium. The next one is Professor Ogumba, surgical management of renal cell carcinoma. 4 modalities: radical nephrectomy, partial nephrectomy or nephron sparing, and also tissue ablation or cytoreductive therapy. Indications for partial nephrectomy being mainly a tumor of less than 4 centimeters as a guide. And he also gave us a preoperative assessment to decide whether what is the benefit of the surgical treatment on this patient. And preoperative assessment, including incentive spirometry, and also complications. He compared open, laparoscopic, and robot-assisted radical nephrectomy, the open being with higher morbidity of trying to heal from the scar. The laparoscopic and robotic being with high cost of treatment. Finally, we had a presentation from Professor Sani Aji, where he considered chemotherapy and immunotherapy or non-surgical treatment. In this, he considered active surveillance specific individuals and also radiofrequency ablation, which he presented as 94% response with a 10-year survival of 80%. He made a very good, he did a justice on immunotherapy, where he considered all the different immunotherapeutic agents, 3 major groups, the TKI, VEGF, and mTOR inhibitors, and also the combination therapy, and also presented a standard way of treating according to European guidelines. He has also indicated that chemotherapy has no role to play at the moment in renal cell carcinoma. So overall, it's a very good presentation, and I think if we have residents going for exam in the next 1 to 2 years, they should get this as a very good lecture, a very good way of writing an essay. So I now hand over to Okeke to accept questions and answers.
Okay, thank you very much, Professor Al-Hassan. Thank you very much. There were a few questions in the chat box. One is asking Professor Ugumba, what is your take on oligometastatic renal cell carcinoma and polymetastatic renal cell carcinoma in this environment? Professor Ugumba.
Okay, thank you very much, Professor Keke, and my friend Takuri for that question. My take on these two scenarios will be a bit different from probably maybe what you may have thought. My take on them will be primary and secondary prevention. I say that because if we listen to Professor Aji's presentation, you will see that today, a lot of the newer agents appear to be out of reach of the average patient that you will see. So perhaps our goal as an organization should be to focus on picking up these tumors early. However, when they do occur and when they are with us in the oligo, or let's take the oligometastatic setting, that's a patient with metastatic disease. We should probably convene a tumor board as a standard practice. The patient should have surgery, as I've outlined, if the patient is fit, and it should include metastatectomy if the tumor size are few. And then some adjuvant techniques should also be offered, as Aji has mentioned. We can pick and choose whichever works. Radiation is a key modality to be considered. That is stereotactic body radiation for this category of patients. For the patient who is polymetastatic, the issues I talked about in terms of performance status assessment using the Sloan-Kettering and the Hen criteria probably come in here. So after assessing the patient, a multidisciplinary approach needs to be followed, bearing in mind what it is we want to achieve and that we're not inflicting more morbidity. But I would prefer that we pick up our tumors earlier. That should be our goal. But when they are with us, an MDT approach with surgery as the key, adjuvant therapies as the newer agents, and stereotactic body radiation should be considered. Thank you.
Okay, to Dr. Paya from Uduma U. He said, from the data provided, what were the common presenting symptoms and what percentage were incidental findings?
Look, Prof, I think that should be Professor Takure's question because he talked about clinical features of RCCs.
Okay.
Am I right? Yes.
You are right.
Yes.
Yeah, the study that we have shows that 1.6% was reported in 1.6 was reported somewhere in Nigeria and 11.8 in Zaria. Zaria reported 11.8. If you reported 1.6, those are the data that we have in the country. But generally speaking, incidental renal cell carcinoma accounts for about 25% of renal cell tumor.
Okay, Fabian HMB to Professor Gumba. What standard time is like? What is the standard time between surgery and commencement of adjuvant therapy? Professor Gumba. Professor Gumba, they're asking you the standard time between surgery and commencement of adjuvant therapy. We have lost Professor Gumba. Any of the presenters?
Okay, can I talk?
Yes, Sani.
Yes, adjuvant therapy. Currently, if the aim of surgery is curative, according to the recent EAU guideline, there is no room for adjuvant therapy. Several studies have been done and there is no clear difference. So the only thing after the surgery is to keep watching the patient, active surveillance. If for any reason they develop any progression, then that is when treatment should be instituted. It is known that since this cancer are immunogenic, sometimes even surgery may be a form of complete cure. So in the recent studies, there is no role for adjuvant therapy in tumors that are really operated with the aim of cure. Thank you.
Okay, there's another opinion in the chat book.
Yes.
It says, can we have a select team of experts across the regions to meet via Zoom and discuss the treatment? Any comments? Somebody is asking for a select team of experts across the regions that will meet via Zoom and discuss treatment.
Well, I think from the discussions now, from the webinars we've been having, organized by NAUS, so far we have only one guideline for the treatment of urologic diseases. That is on BPH. I know there are groups working for CA prostate now. So I think gradually we can meet up where we take priorities. Which one comes first? We started with BPH because BPH is among the most common urology disorder, and then followed by CA prostate. I think gradually, step by step, we'll come to other diseases. That is my take.
Okay, thank you very much. There is a question here. Say thank you, Naus, and the resource persons. Which histological subtype have the best prognosis?
Thank you, Prof. I think that has to do with the aspect I presented.
Yes.
I think it's a chromophobic type, which is a really peculiar type, and 4 to 5% of the histologic subtype has been shown to have the best prognosis. But like I said during the presentation, once you have the sarcomatoid differentiation, almost all the tumors seem to have poor prognosis once you have this kind of differentiation. While the clear cell type has the worst prognosis, chromophobic type seems to have the best prognosis. Thank you.
Okay, there's a question to Gumba. Wonder if it's, well, Sani can also answer. He says, thank you now for this webinar. Following cytoreductive nephrectomy, what is the timeline to start adjuvant targeted therapy?
Well, I think I've answered that.
Answer that. So this is another variation of that question. It's the same thing. Okay, somebody asked whether there is a recording. Yes, this will be recorded and it's already being recorded. It will be posted. The link will be sent to NAU's platform. The chairman of the CME committee wants to make an announcement. Professor Dr. Evarus.
When you start your university, you can make me prof, not yet prof.
Professor in private practice.
Professor of endourology.
Good evening, sirs. God bless you. I want to thank everybody, the participants. We had over 100 participants. We want to thank you all because if you are not here, we'll not be able to continue with this. I want to thank especially the presenters and the moderators, and of course, our ever-present web hosts. I think we're improving in our performance. I just wanted to announce before Sandy will conclude that for next month, we're going to have male infertility. So it's another interesting one. I want to request that as much as possible that we should all be interested in these presentations and participating, because very it's quite a difficult task to get people across the region, as Sharif Ogunlayi will put it, to to present. So please, I want to plead with us as much as possible. In fact, if you're interested in a particular topic, do send us, because I cannot, the committee does not stay in one place and know everybody who is doing everything. But this has been very enlightening for us, and I want to thank you all for the opportunity and ask you to please assist us in making it possible for us to have a more robust thing each time. However, we still have some problem with issues of what do you call it, reception. As much as possible, I mean, we did much better this time. Please let us find the best place if we're going to do a presentation. We'll take your time and make sure we find the best place so that all your efforts in preparing will not be wasted by poor reception. Thank you very much. God bless you.
Thank you, Professor Al Hassan.
Yes,
Any comments?
It has been a very good. It has been a very good presentation, and I think we brought experts from different parts of the country, and that is what NAU should always do. And we feel I will make a suggestion for the upcoming infertility. We have some centers. Let's not restrict ourselves to only urologists. We have some centers that are doing assisted reproduction, gynecologists and urologists combined. So
one of them is going to present.
Good, that's great. So overall, it is being a very good webinar, and the able chairman, Professor Azodo, has actually transformed medical education in urological fields, and I think it's a very good thing. We should allow some of the students, some senior registrars, to participate. It's very enlightening. It's very enlightening to everybody, and I thank everybody attending now. God bless. Thank you.
Thank you.
Our web host.
Thank you. It will be recorded and posted to the NAUS platform.
Please, we need to have the link for our NAUS YouTube so that we can all go there, so that we don't wait for only the links. If you can post the link for the NAUS YouTube so that we can also go there, sir.
Okay, thank you very much. Okay, good night. Happy weekend, everyone.
Thank you very much, sir. God bless you, sir.
Thank you.